Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
That's your next specimen. You stopped answering only, guys, huh? Retained placenta, okay. PPH, all right, okay. Subcenturiate lobe, placental non-separation, leaving in, okay, wait. Placenta, retained placenta, significance PPH, retained placenta, subinvolution. What else? Run your horses wild in your mind. Malpresentations, okay. What else? What else? Okay, I'll give you a hint. It's type 2 of one of the things which I've taught you somewhere. Type 2. Oh. Now my students have understood what I'm talking about. Placenta previa. Oh, great. Pragati got it. It's type 1 and type 2. Type 1 is velamentous insertion and type 2 is with, so you are the gold medalist of my class, Pragati. Clap. Very good. Excellent. What happens is, guys, one lobe of the placenta is here. The other lobe is here. And in between here, you have a leash of blood vessels, which are also going on this placental edge from this placental edge. And maybe they are traversing over the cervical head. And if those blood vessels are coming from the fetus, they are fetal blood vessels. But at the time of amniotomy, what blood is now being dripped out is not maternal, actually it is fetal. And even at term, the fetus has only 80 to 100 ml per kg blood inside it. That means at term, if I'm talking, it's got only 300 ml of blood inside the baby, max. It can also have 250 or 200, but I'm talking about 300 ml of blood total in a fetus. That means one glass full almost, literally. So if 30 ml also goes out, 30 ml is like this much. If it goes out, if it drips out, you'll suddenly have a slump in the heartbeat, bradycardia, or you'll have sudden decelerations, pathological CTG. So that is why they say after doing amniotomy, always check with the CTG. You'll see the induction of labor guidelines anywhere. You will see that immediately after doing amniotomy, check the CTG. Okay, especially if there is blood in the fluid. Very important. So yes, subcenturiate lobe is very closely associated with a condition called as vasa previa. Okay, vasa previa, in which the fetal blood vessels, they traverse from the main lobe of the placenta to the subcenturiate lobe, sometimes traversing the cervical outlet. Yeah, so that was what came in my mind. You all have described the specimen very well. What is subcenturiate lobe and how does it develop? It's nothing. It's just an anomaly. So it's nothing very, very big. Okay. Connected only by fetal blood vessels within the membranes. It's believed to develop due to abnormal placental vascularization. Can happen with anyone. Clinical implications, all of you had written right. PPH, vasa previa, retained placenta, retained lobe. I totally agree with all of you. But vasa previa was one thing which I really wanted to hear from you all because it's not a very straightforward answer. Okay. How is subcenturiate lobe diagnosed antenatally? So ultrasound is the gold standard diagnostic test. How should a subcenturiate lobe be managed during delivery? Very, very essentially that once the placenta has been delivered out, we make sure that it is complete. And if you already knew that this is a subcenturiate lobe, make sure that another lobe is also evacuated from the uterus. Not just that, if you have any doubt, please make sure that you have a ultrasound inside the OT to make sure that the uterine cavity is empty. Okay. If there is any doubt, manual removal of the retained placenta. Okay, what are the risk factors for developing subcenturiate lobe? Mostly actually nothing but multiparity, advanced age, smoking, I would say, multiple gestation, placenta previa, low-lying, so many things. And of course, any uterine surgery. So it's like placenta is developing at one place and then it stops and then suddenly, there's some other needus of its growth possibility.